All right, thanks. This is a good early on the first day kind of talk. A lot of pattern recognition. This is a lot of stuff everybody knows, but it's nice to review. No formulas will be calculated, which is always useful early on the first day. So let me tell you how I learned how to read a head CT. I was in neurosurgery, so I matched into neurosurgery out of medical school. And the way they teach you in neurosurgery to read a head CT is they hand you a beeper and they say you're on call. Go figure it out. And so I struggled my way through it for 3 years before I became one of the smartest people in neurosurgery and changed to emergency medicine. And when I went to emergency medicine in '95, there was no mechanism for an emergency physician to look at their own head CTs. This was pre-PACS, and for plain films, they would send back a plain film of the patient. We'd make our preliminary read. But for head CTs, the only thing asked of me was to dial 4614, which is a number burned in my brain, and just listen. And it would tell me what the head CT showed. And I said, well, what if I want to see my own head CTs? I feel like I know how to read a head CT. It was not possible to read my own head CT, and it wasn't thought that necessarily an emergency physician had the skills to do their own head CT reading. Hence, I came up with a way to teach emergency physicians how to read a head CT. So I don't practice a shift. I cannot imagine there's been a shift in my 15 years as an emergency physician. I work in a level 1 trauma center, tertiary care referral center. I can't remember a shift where I did not order at least a half dozen CTs of some body part or another, but lots and lots for head. Code stroke has certainly upped the ante for that. What I found when I was first putting together a way to teach head CT was that most physicians, particularly at that time, had very little experience with interpretation, but still many, if you look at curricula for residency programs, an awful lot of them don't have any formal curricula for learning how to read a head CT. And I think there's lots and lots of things you need neuroradiologists for, and they're great, but there's lots of things that I think I need to know how to interpret and act on at 2 in the morning without waiting for someone to tell me what's going on. If you look at studies, emergency physicians sort of globally are uncomfortable reading head CTs, or at least traditionally have been. And there's always been, there's maybe 6 or 8 studies out there, and we don't have a great track record. If you do a test on emergency physicians for looking at head CTs, obviously the more subtle the finding, the harder it is to identify. But there's literature out there that says we're not great at it. So the clock is ticking, and there's some things that can wait for Nighthawk if you have that option. I don't have Nighthawk. I have radiology residence, which is, I don't know if it's better or worse, but as of January 1, I'll have someone who's been reading x-rays for approximately 6 months as my expert. So that's who my go-to person is. Nighthawk doesn't publish a lot of their data. In 2009, there was a study that said half their studies are read within 1 hour, which means half are not read within 1 hour. And I think there's some things that I don't want to wait an hour for a finding. And about 1 in 20 has a major discrepancy. So, I teach residents for a living, and I think, I teach them at the end of the day, you need to know how to identify and act on the life threats, and that's why we're here. So in medical school, I learned how to read an EKG by doing Dubin, the little orange book, where you do rate, rhythm, axis, P, Q, R, S, T, and intervals. And what I tried to do is I was teaching my fellow residents as my resident project, how do you read a head CT? How do you break down pattern recognition into a thing that you can do over and over? And it was kind of the same thing. I said, what is a way that I can have you go through a head CT and find all the life threats? You're not going to find everything. That's what neuroradiologists do. They go to neuroradiology school for years to figure that stuff out. And so I will miss a tectal plate lipoma, but nobody dies from a tectal plate lipoma. I don't want residents to miss increased pressure. I don't want them to miss abscesses, tumors, subarachnoid hemorrhage. And so that's what we focused on. Came up with a mnemonic. Blood can be very bad. You can use any mnemonic you want as long as it starts with a B, a C, a B, a V, and a B. The first B is for blood. So obviously one of the things I'm asking myself very early on when I have a profoundly sick or unconscious patient in the critical care room at 3 in the morning, I want to know, is there blood in their head? Cisterns, there's a lot of cisterns that are out there that are named cisterns. There's only 4 I care about because there's only 4 that when something bad's going on will kill you. There's a whole bunch of them, and if you read a radiology textbook, there's 30 cisterns that you can find on a head CT. There's 4 that an emergency physician needs to know about. The brain, obviously the high rent district, is stuff that you have to know about. Ventricles have 2 tricks. They can be big or little, and they can have blood in them or they can have water in them. They don't have a lot of other tricks. But again, at 2 in the morning when I have a patient who's got a GCS of 3, I want to know what's going on with their ventricular system to the degree to decide, is that the problem? And then bone. Bone is usually not what's killing somebody, but it's nice to be able to know what's going on with skull fractures, infections, etc. So using that mnemonic, the idea is you can run through a head CT, and if you hit those 5 areas, you're going to catch the emergencies. Now, the only physics, the CT, if you go to a radiologist talk on if you go to a radiology talk on CTs, they talk about physics a lot. I don't talk about physics a lot. All you need to know is that if it's really dense, it's going to be plus 1,000 Hounsfield units in white. If it's really not dense, like air here in the mastoids, it's going to be the blackest thing you can see on a CT, and that's minus 1,000. And then everything else is somewhere between plus 1,000 and minus 1,000. Water's right in the middle at 0. So here's some water here in a cistern. There's bone, and there is air. That's about all the physics you need to know. Windowing is important to know for just one reason, is that you cannot look at head CT only under one window and know everything that's going on. Remember, it's a grayscale. There's not a lot of shades of gray in order to look at a CT scan. So when you window it, all you're doing is saying, instead of using all the shades of gray that you have available between minus 1,000 and plus 1,000 Hounsfield units, just focus them up here. And I understand I'm going to lose information elsewhere on the spectrum. So when I say window it for brain, I understand I'm not going to have great bone detail, but I'm going to have really good brain detail because I want to know if it's a stroke patient, I want to know, do they have a big hypodensity? So that's when I window it for brain. I just center my window. I say, use all the shades of gray in this particular region. I'll slide that window down and look at the bone in a little while, but right now, give me information about the brain. Then windowing for blood, or if you're on the impact system, it's also the soft tissue setting. That says, okay, I've now looked at the brain. I don't need detail on brain. I need detail on, is there blood in the intracranial cavity? So I've lost my detail on brain because I've slid my window now to center around the density of blood. And then lastly, I'm going to slide it all the way up to bone to look for fractures, infection, etc. And you see, I've totally lost my brain detail, but I can use all the shades of gray just up in that plus 1,000 region so that I have really nice detail on bone. So when I look at a head CT, the only physics principle I'll say is use your 3 settings just to make sure you get a chance to find all 3 parts of the pathologic spectrum. And here's just an example of that. So here's a head CT, and I want to know everything that's going on this head CT. I cannot get that from one particular windowing. So I window it for brain, and I'm looking at the brain, and I see the brain's pushed over, and I see there's probably a little dot of something going on there, and I see the midline's pushed over, and we're going to get to reading a brain. But I don't know everything yet, so I window it for blood, and I want to look at what's going on here, and I can see there's a blood clot there, and there's kind of blood tracking back there. And then I window it for bone, and I say, and I've got a skull fracture. I could not pick up all those pieces of information just windowing it one way. So when you have an impact system, use your windows, your 3 windows that you can use in order to determine what's going on. So standard head CT, remember it's as if you're laying at the patient's feet, looking up at them. And as we look at head CTs, we can't just jump right in and look at pathology till we just remind ourselves of a little bit of normal neuroanatomy, which we'll call this the painful part of the lecture, where we just review the stuff that we used to know. When you come up through the skull base, there's a few features that I always try to use for orientation. I'm going to have the brainstem coming through the foramen magnum. The cerebellum's going to sit posteriorly. And I'm going to have a few bony landmarks in my first cuts that tell me where I am. I have the clinoid bones, which are sitting right here. And they're going to be helpful as I go on and I look for subarachnoid hemorrhage because they sit right in the suprasellar cistern. They point the way to where I'm looking for a subarachnoid hemorrhage. I have the petrous portion of the temporal bone. That's important to me because basilar skull fractures will show up frequently here. This is what gets fractured in a basilar skull fracture. And that's where the mastoid air cells live. And I'm going to find that fracture. Even if I don't see the fracture line, it's going to cause some bleeding into those mastoid air cells. And so I'm going to find basilar skull fractures there. Sphenoid bone is this wing right here and the wing right here. And that's a great place for the temporal lobes. As you decelerate a brain from 70 miles an hour to 0 miles an hour over a second or two, that is a great place to look for contusions because the brain temporal tips are going to slide to a stop and hit that sphenoid wing. And so that's a place I'm looking for contusions. And then as you look at the frontal fossa, you see all these kind of bumps and ridges. And again, in my deceleration injuries, when I'm looking for contusion, hemorrhagic contusion, if you imagine a decelerating brain slowing down really, really quickly, you can think of the frontal lobes just bumping across each one of these ridges as it comes to a stop and then sliding into the frontal bone. So those are the areas I'm looking for frontal contusions on my trauma patients. here's a first, somewhat of a low cut. It's not the first cut you're going to see, but it's the first one that I think is kind of getting into areas I care about. So I've come up through the bottom. I see that petrous ridge right there. I see the mastoid air cells. I'm catching some temporal tip and some temporal tip. I have the ethmoid sinuses here. I've got cerebellum, and I've got cerebellum, and I've got brainstem. Now, what is like kind of med school 101, what do we know about posterior fossa? MRI is better for posterior fossa. Absolutely true. In my shop, getting an MRI takes a small miracle to happen in the same day as I order it. So I never can get an MRI of the posterior fossa. If you can get it, it's great detail of the posterior fossa. Look, you can see the cerebellum. These are about the same cuts. Look at the cerebellum, look at the brainstem, much better detail. But on the other hand, as we go through and look at pathology, I can find major bad things in posterior fossa. If I have a big hemorrhage, I'll see it back here. If I have a big stroke, I'll see it back here. If I have a big tumor, I'll see it back here. I probably won't see as much subtle detail as I would in an MRI, but again, if you work at least a shop like mine, I cannot get MRIs like that. It's a fairly big deal. So coming up a little bit further, I still see those mastoid air cells, and as we start looking at trauma, we're going to look for these. This is the area where we're looking for blood to indicate to me that someone has a basilar skull fracture. We've now got those temporal tips sitting right up against that sphenoid wing, that bony wing right there. This is where I'm looking for deceleration contusions. See the ethmoid sinuses here. I have the cerebellum, and brainstem is starting to come into a little bit better detail as we get up out of that bony ring around it. We lose detail. You see a little bit of streak artifact, which is not uncommon, and that's just at an interface where there's very dense bone that's surrounding a relatively hypodense structure like the brainstem. So when I was putting together how do you teach how to read a head CT, I showed lots and lots of people, lots and lots of CTs with findings on them, and I tried to figure out where do we tend to make mistakes in reading head CTs. And there's clearly a high rent district and a low rent district of the brain. And as we looked at those first few images, we were still in relatively low rent district, but we are now hitting the high rent district of the brain. And there's really three key slices that you're going to see on a head CT where a lot of stuff happens in a very little space. And there can be subtle findings there that can explain an awful lot of what's going on bad with the patient. So the first key slice that I always, that as I look at CTs that I pay extra attention to be sure I'm looking at is at this first level right here. It comes through the middle of the cerebellum. I catch the fourth ventricle. I catch the brainstem. And I'm going to see the first cistern that as an emergency physician I care about, which is the circummesencephalic cistern, or the ring around your midbrain cistern. And the reason why I care about that one is if you do a craniotomy on me right now and somebody comes up here and starts just pushing on the top of my brain, pushing down, and we can do serial CTs as we do that, the first place you're going to see me get in trouble with pressure is that circummesencephalic cistern. It's just a jacket of CSF that's percolating its way back up. It came out of the fourth ventricle. It's percolating its way back up around the brain. And it is the canary in the coal mine for intracranial pressure. It is the first place as you start putting pressure on a brain and things start getting tight, this is what goes away first, this circummesencephalic cistern. So it's an important finding for me, especially if it's this patient's altered and I'm trying to decide am I going to do an LP on them or not. And when you send that patient to radiology and you say, do they have increased intracranial pressure? Now we know that CT is not always a perfect study for that, but if this cistern is obliterated, that ups the ante. That makes them start thinking, yes, this patient probably has increased intracranial pressure. So that circummesencephalic cistern, that ring around the midbrain, is an important structure for telling me that there's CSF working its way up. There's not increased intracranial pressure on this patient. Now, the only thing, this is a really nice cut. If the patient's not perfectly oriented in the scanner, you won't get it all in one cut, and you may have to put it together out of two cuts, the cut below and the cut below. So I can get the front half of it here. The next cut would give me the back half. This cut is nice because it gives you the whole thing all the way around, that circummesencephalic cistern, the ring around the midbrain. Other things I see at this level, I see cortical gyral pattern. I'm still seeing the ethmoid and the sphenoid sinuses back here. And so those are things to note, but the key thing at this level is that circummesencephalic cistern. If you're kind of trying to conceptualize where we've come through the brain right now, so we hit the pons, this is the cistern, this is the fourth ventricle. So that key level, you're going to catch that somewhere in that cut. The next key level is a little bit higher, so we're going to still see some cerebellum. We'll get a little bit of the brainstem, But we're into what's really important, which is my suprasellar cistern, which is the second. So remember, I said there's 4 cisterns I care about as an emergency physician. The suprasellar cistern is where the circle of Willis lives. And that's really, really important when I'm trying to decide if a patient has a subarachnoid hemorrhage, because about 80% of aneurysmal subarachnoid hemorrhage happens somewhere in this circle of Willis. So about 80% of the time that I'm going to find it, this is where I'm looking. I have the carotids come up and they branch off into the middle cerebral, the anterior circulation, the posterior circulation. So this is the area where subarachnoid hemorrhage likes to live. Just show that on a scan. So here's that suprasellar cistern. It's going to be darker and full of water, so it's going to give you the density, the Hounsfield units of water. I see my brainstem down here. I'm still catching some of my circummesencephalic cistern, and again, that depends a little bit how that patient was tipped in the scanner. That's a radiology technologist judgment of how they angle the scanner versus how the patient's head is in the scanner. So you can see both on the same. Sometimes you'll see one and then the other. But I know my middle cerebral is reaching out here, my middle cerebral is reaching out here, anterior circulation comes up here, my posterior circulation comes around here. My circle of Willis lives here, so if somebody comes in and I'm worried they have a subarachnoid hemorrhage, this is where I'm paying a lot of attention, is to the circle of Willis. Another cistern, just because we catch it here, is the Sylvian cistern, and this is the third one that I'll mention. The Sylvian cistern lives out here, and that's the very distal area of the middle cerebral artery, and I mention it, if you're only going to remember 3, ignore this one, but if you're going to remember 4, keep this one in the fold. You can have distal middle cerebral artery aneurysms that only leak out here into that Sylvian cistern, and they don't reflux blood back into the suprasellar cistern. So you can see subarachnoid hemorrhage that shows up just out here in those Sylvian cisterns. It's pretty uncommon, but I've been doing this for 15 years as an emergency physician, and I see it maybe once every other year where somebody has subarachnoid only in that particular region. Just to conceptualize again where we've gotten, so here was our pons, there was our pituitary, we're now above that. We're almost out of the cerebellum. We're going to start hitting the basal ganglia up here. Middle cerebrals come out there, anterior circulation and the posterior circulation. The other thing, so the other thing I care about at this level, besides that star-shaped suprasellar cistern, is the temporal tip of the lateral ventricle. And the temporal tip of the lateral ventricle shows up on the same cut as that suprasellar cistern. And this is a normal configuration. When we start looking at pathology, we're going to see big swollen temporal tips. You say, well, why do I care about it there versus elsewhere? The same way that circummesencephalic cistern is the canary in the coal mine for increased intracranial pressure, the temporal tip is the canary in the coal mine for increased intraventricular pressure. This is the capacitor for the CSF. So the first place I look for somebody who I'm worried about has hydrocephalus is on this same cut, this temporal tip. And it's described as looking comma-shaped. It should be small and comma-shaped. And as we look at pathology, you're going to see ones that are not small and are not comma-shaped. But this is a normal configuration. And the way I make sure I remember it is I know that 1 in 5 people with subarachnoid hemorrhage have acute hydrocephalus associated with it. So the same cut that makes me look at the suprasellar cistern also makes me look at that temporal tip to be sure I check and see if they have increased intraventricular pressure. Then we hit our third key level. We may or may not catch a little bit of the cerebellum, and then we hit our last cistern, the number 4 cistern, which is the quadrigeminal cistern. The quadrigeminal cistern, there's 2 things that can happen in the quadrigeminal cistern. One is that once you lose your circummesencephalic cistern, this is the next one that can go. So if, again, somebody does a cranie on me and you start pushing down on my brain and do serial CTs, first thing I do is I lose that circummesencephalic cistern. That's the early warning system. Then I lose the quadrigeminal cistern. That's the late warning system. That's someone who's having increased intracranial pressure and rostrocaudal herniation. This is where I'm going to see that happen, is loss of this W-shaped quadrigeminal cistern. The other thing that can happen there is venous subarachnoid hemorrhages from rupture of venous lakes that happen in this region of the midbrain. It's a benign cause. You treat them like every other subarachnoid hemorrhage because you don't really know that until you've done all this stuff. But when somebody has only subarachnoid hemorrhage back here in the quadrigeminal cistern, that's a good sign. If I have a subarachnoid hemorrhage today, I pray it's one of those because those generally get better. You don't have to do anything. You don't have an aneurysm. And importantly, they don't get into vasospasm. So here's that quadrigeminal cistern. There's the Sylvian cistern. Look for that W-shaped lake of CSF posterior to the upper part of the colliculi of the brain. The ventricular system, I just mentioned it specifically here because we've kind of been seeing it as we go up. We saw it on all 3 of the key levels. On key level 1, we saw the fourth ventricle. Then on level 2, we saw that temporal tip, which is the capacitor for the system. And then level 3, we get an idea of that third ventricle. Remember, you make CSF out here in the lateral ventricles. It has to get through a narrow spot right here, the intraventricular foramen of Monroe, to get into that third ventricle. So problems that happen here, if you have a hemorrhage into the third ventricle, if you have a tumor right here, can trap one or both of the lateral ventricles, and they'll continue to make their CSF while that happens. We make between 0.5 and 1 cc of CSF a minute, and that equation cannot be pushed backwards with increased intracranial pressure, increased intraventricular pressure. It does not slow down depending on how much pressure is in the ventricular system. So just because you have incredibly high intraventricular pressure, you will continue to make your 0.5 to 1 cc a minute. Your total volume is 150, and you turn it over a bunch of times a day. So you make and absorb a lot of CSF in a day, but this is kind of the time that's ticking. If I trap a ventricle, if somebody has a subarachnoid and now they have acute hydrocephalus, or they bleed into their midbrain and they now have acute hydrocephalus, this is the clock that's ticking, is I'm going to keep making CSF, and if it can't get out, it's just going to keep expanding. So once you get out of the high rent district, you're back in the low rent district of the brain. As I was testing people, when I first was figuring out how do we teach how you read a head CT, it was very unusual that people missed diagnoses once you got out of the basal ganglia region of the brain. Epidurals, subdurals, which we'll look at, are much easier to identify and are not as subtle as things like increased intracranial pressure, subarachnoid hemorrhage. So, it's important to look at all the cuts you have, but it is unusual you will miss pathology up here on the higher cuts, but it is not hard to miss pathology on those lower cuts. So now we get out of the painful part of the lecture and move on to the more enjoyable part of the lecture, which is looking at pathology and examples of all the bad things that can happen inside somebody's brain. So using that mnemonic, blood can be very bad. The first B is for blood, and there's 3 things you have to do with blood, which are kind of intuitive, but I figure if I don't say them, then somebody might say, you didn't say them. So the first question is it there? Which is easy. And when I was testing, going to residencies around the Southeast during my research, most people, most residents and attendees could say, yes, there is blood. I have identified blood on this CAT scan. And so that was the first level of difficulty, and most people didn't have trouble with that. The next was, what is it? Is it subdural? Is it epidural? Is it intraparenchymal? Is it subarachnoid? Is it intraventricular? And that was a degree of difficulty harder. So if a lot of people knew there was blood, less people knew exactly what to call it. They knew there was blood, but they weren't exactly sure what it was. And then the hardest one was they knew there was blood, they knew where it was, but they had trouble classifying how bad off is this person based on this CAT scan. How bad of a problem is this? Because you can have bad-looking CAT scans and good-looking patients, and bad-looking patients and good-looking CAT scans. So those are sort of a degree of difficulty. Each one is a little bit degree of difficulty harder than the last one. So some basics about blood. We know acute blood is going to be bright white once it clots. If it's not clotting, it is going to be isodense. And you can see there's a little area within this big white clot here. There's a little area of isodense there. If this whole clot was that density, you would have a lot harder trouble seeing the difference between what's going on here and what's going on there. So this is a small area of non-clotting blood. There's once in my 15 years of looking at a lot of head CTs where we've had a patient whose INR was so high it was unmeasurable, and they had blood in their head, but it was initially missed because it was not clotting. So unclotted blood is very hard to differentiate from brain. We know it becomes isodense at about a week. And why is it about a week? Why can't we just decide how long it takes? Well, the way blood goes away is the macrophages come in from the outside and they chew up the heme. And as the heme gets chewed up, that is where it becomes isodense. But if it's a big fat clot, that takes longer. And if it's a little thin clot, that takes shorter. So it's sometime around a week, most clots will be digested and it will be isodense. So you see there's an isodense problem here. It's very hard to tell the difference between this substance and this substance. You get a sense, I see the right lateral ventricle, I don't see the left lateral ventricle, so you get a sense something is going on. But this is exactly what I would expect about a week out from somebody's head injury. And then we know by 2 weeks, almost everybody's blood collections will be hypodense. So your macrophages have had time to do their shtick. They've digested the blood, and now it's going to be more the density of sera or of water than it is of blood, and it's no longer isodense. It's certainly not hyperdense. It's going to be isodense at that point. So what kind of blood, as an emergency physician, do I think, I hope all of my residents graduate saying they can just stand across the room and say epidural, subdural, et cetera. So epidural, lens-shaped, we know it's caught at, it can't go past a suture. So I have the coronal suture of the skull right here, so it's not going to cross that suture. And I have the lambdoid suture of the skull back here, so it's not going to cross that suture. I know it's an epidural because it's not crossing sutures. It's generally lens-shaped. It doesn't have to be between this suture and this suture. It can be between this suture and this suture up here. It's just a collection above the suture. But it's classically, we think mostly it's somebody with an injury to their middle meningeal artery. When I was wearing my neurosurgery hat, we loved epidurals because an epidural is fundamentally not a brain problem. It's a blood problem. It's just blood in the wrong place. And if I get this clot out of here before this patient is unconscious, they do great. These patients do really, really well. They wake up, they go home, they have a normal life. This is not that this brain is all injured. It's just simply there was an injury to a blood vessel, and it's collecting in a place where there's pressure. So there's blood, it's epidural, and it's effaced this lateral ventricle. There's midline shift associated with it. So there's trouble with this one. But if I can get this out before that patient before they are unconscious, they're going to do well. So here's another place you can hide it. So again, it doesn't have to be that middle meningeal artery. So here's one that got between the coronal suture and the frontal suture up here. Again, it's just a collection above the dura of blood. You can see some air density located within it also, so you know there's a skull fracture associated with it. You can hide them up in the temporal tips. You can have epidurals in the temporal tips, either side. And then this is every year I have my favorite CT of the year to demonstrate a principle. So this is a 4-month-old I saw on December 23rd, 2 days before Christmas in 2012. It's a 4-month-old who came in with a right gaze preference, who the story was had rolled off the changing table. And kid was worrisome, but not sick, was eyes open looking at us, just was neglecting their right side. So I go with them to CT scanner, and as the images are coming off, I'm like, all right, something's going on. Holy crud, this is a big collection. Holy crow, it's half the kid's brain. So you say, this kid's got a big problem. He's got an epidural, so it's blood. Where is it? It's, it's between this suture and this suture. And what's it doing? Well, there's not much room left for brain. Kid goes to the OR, gets it sucked out. This is post-op. Immediately post-op, get a CT scan. Has a little bit of residual blood. Still, you can see that it's not perfect, but 1 week later, it's a normal CT scan. If nothing else demonstrates that this is a blood problem and not a brain problem, this CT does, because this 4-month-old, half his brain was a blood clot. When it came out, the brain is fine. The brain was not the problem. It was just a blood clot. Now, the kid was helped by being 4 months old, and the sutures could expand and absorb some of the pressure. But epidurals are a blood problem. That's as opposed to a subdural. The subdural is what neurosurgeons hate, the acute subdural, because an acute subdural is not so much a blood problem. It's a brain problem that has a marker of a lot of blood associated with it. So it's going to cross sutures. I know it's a subdural because it's crossing this suture line right here, the coronal suture. So it's below the dura. It's tracking along. It's falx or sickle shaped. But it's not, the problem with this person's brain is not this collection of blood. If you look at this brain, there's, here's the right lateral ventricle. There's no left lateral ventricle. If you look at the density here, it is just, it's a homogeneous mess. This brain is unhappy. There's no cortical gray-white differentiation. There's midline shift, and that's not coming from this blood collection. You remember that huge epidural we just saw. Half that kid's brain was blood, but it didn't have unhappy brain. So the problem is you take this person to the OR, which happened, this comes off, you suck out the clot, but the clot is not the problem on acute subdural. This is the problem. It's all this dead and dying brain underneath it. So this is the classic one. You take off the bone, and as soon as you do, the brain is herniating out of the wound at you because there's so much pressure. And getting rid of the clot, while it's going to go away, doesn't fix the problem. The problem in acute subdural is really this brain right here, is that this is all damaged brain. It's not going to get better. Just a few other looks at subdural. So here's kind of an intermediate age one. It's not the bright white and of acute. It's not hypodense. So you can see there's been some digestion to it. So there's the macrophages are trying to do their thing. And just as a comment about chronic subdurals, we've all seen people with huge chronic subdurals who are walking around. Different problem. A slow, your brain can accommodate a slow problem, but the acute subdural is almost never going to be that patient. It's going to be the patient who's profoundly unconscious. Here's some more acute subdural with subarachnoid hemorrhage associated with it. And then an acute on top of a chronic subdural. So here's a look, a kind of a classic look of a chronic subdural. You know the patient survived this one because it's already, you know, it's more than a week out. It's been digested. This is, as they lay on their back, it's called the hematocrit effect. You can see their crits a lot. It's like 50 per, 46, 50. And this is all sera, that's all cells. But then they fell again, and they now have an acute subdural on top of it. And so is their blood, what is it? Subdural, both acute and chronic. What's it doing? Well, unfortunately, this is the left lateral ventricle. This is the right lateral ventricle. This is midline right here, or this is what they're supposed to be. So they survived this one okay, but this one on top of it, they had a horrible outcome because you can tell this brain is so unhappy. You can hide subdurals just two other places worth mentioning. It can track posteriorly and come down over the tentorium and kind of spill over both sides of the tentorium, so you can occasionally see it look like that. It can also track up and go along the falx, so you can see it tracking along one side of the falx, just to know that that's a possibility for subdurals. Those are places where they typically get hidden. But on the other hand, if somebody has somebody's not going to be, if they only have enough blood to just subtly track along the falx, they're not going to be profoundly unconscious. They're not going to be super sick. So subarachnoid hemorrhage, we know for subarachnoid hemorrhage we need to look for blood in the cisterns. Aneurysms get about 80% of them, AVMs maybe 4 or 5%, vasculitis a few, and then maybe 10% is around the range where there's never a cause found, and those are usually thought to be, like I said, those venous subarachnoids. And remember, 1 in 5 people with an acute subarachnoid who hit your door are going to develop hydrocephalus very shortly after their subarachnoid hemorrhage. I work at a receiving hospital for the whole state of Maine, and we have really long transport times. So we may get someone who had a subarachnoid hemorrhage 6 hours ago, so they've got that problem, and then they hit our door and we rescan them, and they've now got 2 problems. And the one that I actually need the neurosurgeon to really do something fast about is frequently the acute hydrocephalus. So that's something that I look at and I want to know right away, is this the 1 in 5 who's going to get that? Because if they're going to get I need them to get a ventric now in order to get rid of CSF. There's a whole other talk today or tomorrow about the sensitivity of CT for subarachnoid. I will say it's an evolving understanding, and I think the literature is not perfect on this, and I think CT is really, really good for for high volume subarachnoid hemorrhage. I think we're flying blind on small subarachnoid hemorrhages. That's just my interpretation of the literature. I read all of that literature. I think it's really, really good. I'm just not sure it's 100% as has been advertised in some literature. I think it's high at 0 to 12 hours, and I think it drops off after that. I think in the end it depends on how much blood, and we've never done a study that tells us how sensitive it is at different volumes of blood in the CSF, a little versus a lot. I think it's great at a lot of blood. We just don't know how good it is at little blood. The generation of the scanner, which is getting to be less of an issue. It used to be that there was big drop-off from the major medical center to the smaller medical centers. Now everybody's got a fancy scanner. And I think it's really important, who is reading the scan. So subarachnoid, it can be really super obvious. So is there blood? Yes. What is it? Well, I remember that's where that suprasellar cistern is, and I know that's where the circle of Willis lives, and I know it's supposed to be black and full of water, and instead it's white. It's refluxing out here into the Sylvian cistern, refluxing out here. It's refluxing into that circummesencephalic cistern. It's everywhere. So this is hopefully one that no one would ever miss. You see that temporal tip, however, for this much blood, this person actually has a pretty nice looking temporal tip, though I'm not super excited about them having the acute hydrocephalus. A little more subtle on this one. You see there's a blush of blood. Again, I want that suprasellar cistern to be black, and I got that blush of blood right there, and I can see there's some blood tracking around in that circummesencephalic cistern. Here's one. It did reflux into here, but you see nice. This poor person wound up having an MCA aneurysm out here, and so they first bled here, and it refluxed back into the suprasellar cistern. Here's another one that had an MCA aneurysm out here. They, again, reflux back to help you find it, but they can just bleed out here and not have to track the blood all the way back. And then more subtle, this is a picture of vasculitis. When you see just little collections of subarachnoid hemorrhage here and there, if it's not trauma, it's vasculitis. If it's trauma, they just have traumatic subarachnoid hemorrhage, which isn't a huge deal. It's a marker for a head injury, but it's not a huge deal in terms of management. If it's a medical patient, and I see a little bit of subarachnoid here and a little bit of subarachnoid here in the Sylvian cisterns, and I see a little bit of subarachnoid here in the quadrigeminal cistern, that just tells me there's little blood vessels, irritated blood vessels here and there that are just letting out a couple hundred red cells here and there, wherever they're most inflamed on the surface of the brain. And then here's just probably the subtlest one, a little bit of traumatic subarachnoid hemorrhage, just layering out in the gyri across the convexity of the brain. Now, we don't think of those with aneurysmal subarachnoid, but this is the classic place where I look for traumatic subarachnoid, just layering out in those gyri, broke a few blood vessels, spilled a few hundred red cells, and it just settles into the gyri. Other places, so we're still on that B, but we'll move on shortly from the B, and from blood can be very bad. I can have blood intraparenchymally, I can have blood intraventricularly. We used to, for some reason, stress about which place we thought it started in order to guide management. It really doesn't matter where it starts because management is the same. The only thing I need to know, again, is if I have blood in this third ventricle, so you see a nice example here. This is somebody who's bled into their third ventricle, and there's that intraventricular foramen of Monroe there and there. The one thing I know for sure is if this patient is going to live, if they have a salvageable exam and somebody's going to do something, the very first something I need done is to get somebody who does ventriculostomies to put a ventriculostomy on this side and a ventriculostomy on this side, because CSF will not be able to get out of these lateral ventricles, and it's going to accumulate 1/2 to 1 cc a minute. And so if they are salvageable, my number one job, besides telling the neurosurgeon I got someone with blood in their head, is, and I need you to come put a ventriculostomy in this patient because they cannot drain their CSF. Intraparenchymal, when you see intraparenchymal blood with a lot of edema associated with it, it's usually bleeding into a tumor. Traumatic contusions generally don't have much edema associated with them. So this was someone who had a tumor and they hemorrhaged into it. So is there blood? Yes. Where is it? It's intraparenchymal. What's it doing? Well, here's the left lateral ventricle. Unfortunately, here's the right lateral ventricle, which is now almost a midline structure. Here's that quadrigeminal cistern down here, which you see is kind of turning to the patient's left. The brainstem does not like to be turned in any particular direction. So this, I would imagine, this patient would be profoundly unresponsive because their brainstem is being twisted. It won't do that. So we move on to cisterns. There's 4 that I care about, like I said: circummesencephalic, suprasellar, quadrigeminal, and sylvian. What am I going to look at them for? Well, ironically, I'm going to look for blood again because subarachnoid hemorrhage is one of the ones that we tend to miss as emergency physicians. So I go through and I look for blood. Then I go through, and as I teach the residents, I say, just make sure that those 4 cisterns don't have any blood in them specifically. Look in those 4 cisterns that we care about, and then just decide, are they open or closed? So here's someone who's got, you can see their cisternal system, subarachnoid hemorrhage, circummesencephalic cistern. Everything is tight, and there's really no room for CSF. So there's blood, and the cisterns are not open. So this is somebody who's both bled and has increased intracranial pressure. Here's another person. Here's that quadrigeminal cistern. This is really the same cut on 2 different patients. This is, and this is a younger male and an older female. And unfortunately, as we get older, we don't have more brain. We have less brain. So I would expect there to be more room on this person's CT than on this person's CT. So looking at that quadrigeminal cistern, that canary in the coal mine, I'm looking for loss of space. I saw it on the prior slide. I lost that circummesencephalic cistern. This is someone who's not only lost the circummesencephalic, but now they've lost their quadrigeminal cistern. Again, checking the sylvian cisterns, looking for subarachnoid hemorrhage. This is your last chance to find it in the mnemonic. If you didn't see it when you went through the look for blood, just checking the 4 cisterns we care about. Just look and be sure there's no blood. And again, look for pressure. There's another really tight brain, loss of quadrigeminal cistern, and loss of all the gyral space all the way around. But this is a representative cut. This is basically the same cut on 2 different patients. Quadrigeminal cistern, what I expect. Quadrigeminal cistern, what I get. This is one who I would not, for anything, put a lumbar puncture needle in their back because I would be very concerned this person would herniate. Middle B is for brain. The things that brain has to do, or that normal brain shows me, is it has nice gray-white differentiation. So you see cortical gray matter, which is denser than subcortical white. Denser is whiter or lighter on a CT scan. So my cortical gray matter should be lighter than my subcortical white matter. There's more water in the subcortical white. There's more nuclei and cell stuff in the cortical gray. And this differentiation is where I'm looking for my early stroke signs. Cortical matter is metabolically much more active than subcortical matter. This is where the cell bodies are up here. So if I take away the blood supply to, say, this quadrant of the brain, the first thing that happens is these metabolically active cortical cells stop being metabolically active. When cells stop being metabolically active, they start taking on water. When they take on water, this cortical matter is going to start taking on the density of the subcortical white because there's more water down here. So when I lose this gray-white differentiation, that's my, hey, this person, I'm worried this person's having a stroke because I've lost the differentiation between cortical gray and subcortical white. The other thing that, when I'm looking at the brain is I like to look for side-to-side symmetry. Frequently, stroke problems in particular are a unilateral problem, which is fortunate, so I can compare one side to the other and decide is it similar or dissimilar. So what are the things that I can find? Again, there's some really obvious ones. So this is one, nobody's going to miss this one here. I generally start with an obvious example and work my way back. There's something going on. You can see there's hyperdensity here. I suspect this is the tumor. I suspect this is all edema associated with it. I see that my right lateral ventricle has shifted and become kind of if this is midline on this patient, it's now into the left side of their brain. Left lateral ventricle, they're still draining their CSF, but this is someone who's going to be really, really tight from all the swelling associated with the edema. Move on to a little bit more subtle. So you see, again, if I'm looking at my gray-white differentiation, I've got gray-white differentiation even over here where something's going on, but I do not have side-to-side symmetry. I have hypodensity here where it's all the density of water, and I do not have that here. This winds up being the tumor here with an area of necrosis right in the middle of it, right there, so that's a little more hypodense. C minus, C plus, what does it get you? Well, in the old days, about 80% of tumors were visible on C minus, and the kind of the radiologist mantra was you could miss about 20% of tumors if you don't add contrast. So we used to always say, well, if we're worried about metastatic tumor, let's go ahead and add contrast. That number is really vanishingly small now with modern generation scanners. You are going to miss vanishingly few. It's going to be in the couple percent range that would be only identifiable on a C plus. That are not identifiable on a C minus. So you will see some evidence in a 5th generation scanner, or 4th, 5th, 6th generation, whatever you're up to now. It is very hard to miss a tumor because you will catch subtle edema. So this is not a subtle one, but just to show you the difference between C minus and C plus. Though there's 3 things that light up with contrast. So the first one is tumor, next one is abscess, and then the third one is blood clot. So the rim of a blood clot where there's the blood-brain barrier breakdown. Those are the only things that light up. So I've only got 3 possibilities. If I give contrast and it shows up, it's going to be one of those 3. It's a tumor, it's a resolving hematoma, or it's an abscess. So here's my C minus, same exact cut with C plus. So it all breaks down here. I see lots of edema. This is going to be a tumor. A little more subtle, again, if I'm doing my gray-white, looking at my gray-white, I got good gray-white side to side. I still have differentiation of cortical gray from subcortical white, but if I'm doing my side-to-side look, there's something going on here that's not going on over here. So I wouldn't have missed this one without contrast. I can tell you there's something going on. The way it almost always works is I send a patient for a C minus, and the radiologist calls me and says, there's something going on, I'm adding contrast. And I say, sounds good. And they send me back these 2 images. I wouldn't have missed it with this. They add some contrast, and they can say, well, there's a problem, and there's a problem. And so this is somebody with metastatic disease. The hallmark of metastatic disease, there's more than one, and it's at the gray-white interface. So wherever you would think about cortical gray and subcortical white coming together, that's where metastases tend to show up on a brain scan. Atrophy just looks like not enough brain, too much water. This is really advanced atrophy, as is this. You see those Sylvian cistern, quadrigeminal cistern. You can kind of see between every cerebellar fold in there. This is just very advanced atrophy, but similar here, big cisternal spaces, big ventricles, but the ventricles are not compressing the brain. There's just lots of water space no matter where I'm looking in this brain. Abscess, again, kind of an easy. This patient's going to be crazy sick. Looking at my brain, I have loss of gray-white differentiation. I have loss of side-to-side symmetry. I have pressure. My right lateral ventricle is compressed over. If I give some contrast, again, if it's an abscess, tumor, or blood, it's going to highlight. So this wound up being abscess. Now this will be the one that's the subtle one. This was a very small abscess that was initially missed. This patient, every one of these CTs almost has a story. Oh, sorry, I didn't mean to do that. The only story I'll tell, and this is the one where you always tell yourself, never tell a patient something can't possibly happen. My partner, every time he does that, that exact thing has happened. So this patient bent over to tie their shoelace on the bumper of a Mini Cooper, and as he came down, he put the antenna up his nose. And he came in to see my partner, and he said, I'm afraid I poked myself in the brain with that antenna. And my partner said, I assure you, sir, you cannot possibly poke yourself in the brain with a car antenna. The guy comes back 2 days later, altered mental status, fever, nuclear rigidity. This is his scan. It was a very subtle, it was an isodense abscess, and this was one that we only picked up once we gave some contrast to. But the take-home message is never promise them it's not possible to do the thing they said. And if you're worried it's a really, really subtle, that 2 or 3%, then go ahead and give some contrast. Hemorrhagic contusion, like I said, it's going to be in the places where if a brain decelerates, it gets hurt. So across that frontal fossa, or up against the frontal bone, or along the temporal ridge down there. It's going to be somewhere where the brain and the bone came together. And what's the hallmark of a contusion? How do I know this isn't a bunch of intracranial hemorrhages from some other thing? Well, there's just no edema associated with it. It's just blood, but not with all that edema like we saw on those other intracranial hemorrhages. So these are all just classic, smaller, bigger, medium, going to be pretty bad contusions. And the problem with these things is that they're going to swell. So if they, whatever they look like today, I know they're going to get much sicker over the next 3 or 4 days as the brain swells and then starts to come back down. And those are just, if you look on the pathology, it's the places that make sense: temporal tips, frontal lobe, that's where you get them. Just some more contusion. And then moving up to the top cuts, only a couple times in my years of doing emergency medicine have I found problems only on the top cuts. But this was one of those patients, and it was someone who had, I was going through and their scan looked fine until I got to these last 2 cuts on the whole thing. And all I could say is that there's something going on this side that's not going on this side. There's a different gyral pattern. There's room on this side. It's tight on this side, but it wasn't causing midline shift. And this person had an infiltrative tumor that was infiltrating the brain but did not have a pressure phenomenon. So it hadn't pushed the falx over. It was just replacing brain with tumor. And so this was the look of it. I only found it on these last 2 cuts. Until we gave contrast, you wouldn't see it on any other cut. Mass effect is easy to measure. You just find midline, and then you find a structure that should be in the midline, like the septum pellucidum, and then when you're talking to a neurosurgeon, you can tell exactly how much midline shift the patient's experiencing. Strokes, we now know what to look for in terms of strokes, looking for big hypodensity, more than 1/3 of the MCA distribution, or at least that's our latest recommendation to be watching for as a sign that somebody's stroke is not acute. So when I'm looking for my gray-white differentiation, here's that, just a nice example of loss of gray-white differentiation, mass effect associated with it. If somebody gets through this phase of a stroke, this is what they left with. They still have loss of that gray-white. This is all dead brain, a little bit of hemorrhage you see right there in it. Lacunar strokes, just any hole in the basal ganglia. Somebody with a good story is probably a lacunar stroke, although you're not seeing today's lacunar stroke when I CT them. I'm just using today's CT to tell me they have risk factors for stroke because they've had prior lacunar strokes they probably were unaware of. But it's just any hole, anywhere in the basal ganglia. If you find a hole in somebody with risk factors, it's probably a lacunar stroke. Visible vessel. If you're in a shop that does interventional radiology, or you send to a place that does interventional radiology, there's a lot of research going on right now about what to do with a visible vessel. Is it going to get better with IV TPA? In our shop, we have a very aggressive IR group, and these patients, while we give them IV TPA, we almost immediately activate an IR pathway in order to give them intra-arterial TPA with the visible vessel. But blood is bright white when it clots. Doesn't matter if it's in a vessel or out of a vessel. If it's clotted, it's bright white. So this is just the middle cerebral artery, right where we expect it to be with blood. And this is if you don't get it canalized, which this person did not, what you expect the outcome to be. Intracranial air. All intracranial air tells me is that there's a hole from the outside to the inside somehow. I frequently cannot find the hole. I can't not find necessarily the fracture, and I can't tell you exactly where it came in. But if you see air inside, that means it got there somehow. So there's a fracture, and there's a communication from the outside of the brain to the inside of the brain. You can be a little, it can be a lot. V is for ventricles. Ventricles, again, only can do a couple things. They're supposed to be black and full of water. Here's one that's white and full of blood. They can be bigger, they can be little, or they can be regular size. Now, if you just show me this ventricle and ask me, does this person have hydrocephalus? I say, I don't know. I have no idea. If I only look at the ventricle, you don't give me any other information, I can't tell, because I can't tell if they have big ventricles because they don't have very much brain. So I have to get other pieces of information. I see big ventricles, but then what do I not see? I don't see cortical gyri. I see I'm losing the gray-white differentiation. So giving the other information, I'll say, yeah, this person has acute hydrocephalus. But it doesn't, if you just show me the ventricle, I can't tell you that. Here's a couple examples. So third ventricle, lateral ventricle, look at the temporal tips. Remember what they're supposed to look like a small comma or a slit. The first place that it grows is right there, the temporal tip. And that's telling me that's my early warning system. Now, I don't need early warning on this one because I got a late warning problem going on both of these scans. But that's my early warning system. But, again, if you don't give me the other information, I can't tell you. I will tell you this kid's ventricles are way bigger than those last 2 kids' ventricles. Huge left frontal, huge right occipital horn. But look at the Sylvian cistern on this person. Look at the gyral pattern. So big ventricle does not mean hydrocephalus. I need the other information to tell me, is this an acute hydrocephalus, too much pressure problem? This kid just has a lot of water and not that much brain. So this is not an acute, oh my gosh, problem. This person had a, presumably an anoxic injury or something, and they have loss of brain in favor of water. And then just there's the temporal tips kind of in the early warning stage. You see this person's had some blood in their third ventricle, and here's the temporal tips that are starting to dilate up. The only other sign that a ventricle can do is something called transependymal flow. You can see this black sort of shading of the anterior ventricular tip right there. That's CSF being squirted out into the substance of the brain. When the ventricular system cannot figure out what else to do with water, the ventricles are as big as they can get. All the gyral pattern is gone. There is no other place to put it. It starts just squirting. It will exceed the pressure that can be held in the ventricular system, and it squirts out into the substance of the brain. That's a premorbid finding. This is an extremely high ventricular pressure. And then last B is for bone. Bone, if you window bone, it gives you a much better idea. So you get rid of the brain, get rid of the blood, and then you can really look and say, okay, I see what's going on. There's a big fracture fragment here, a big fracture fragment here. Think about the petrous portion of the temporal bone. That's where skull-base fractures happen. Now, if there's not much movement at a fracture line, you won't see a fracture line, but you will get bleeding at a fracture line. So here's a patient who's had a trauma, and I look at that petrous portion of the temporal bone, and the mastoid air cells, on this side, they're black, as I would expect them to look like, but on this side, they are not. There's fluid in them on this side. Now, unless they were driving really